Hi, my name is Dr. Melissa Nguyen. I am a pain clinical pharmacist specialist at the VA Palo Alto Healthcare System. Today we'll be going over opioid tapers. I have nothing to disclose, and we'll be discussing the off-label use of Suboxone and Subutex for pain. By the end of this presentation, you will learn how to recognize the appropriate patients for an opioid taper, design an individualized and patient-centered opioid taper, and outline how to use a buprenorphine bridge to facilitate an opioid taper. Prior to initiating an opioid taper, one should evaluate the risks and benefits of the opioid therapy. For instance, if the patient demonstrates lack of efficacy, there's no improvement in function, if there's inadequate pain control, or failure to reach the established treatment goals, the patient has severe unmanageable adverse effects, such as refractory constipation, cognitive impairment, drowsiness, or if the patient demonstrates non-adherence to the treatment plan or unsafe behaviors, such as early refills, lost or stolen prescriptions, or buying and borrowing opioids, if they demonstrate concerns related to an increased risk of substance use disorder, such as those aforementioned behaviors, age less than 30, family history or personal history of substance use disorder, patient-specific factors such as medical comorbidities that may increase the risk of respiratory depression, such as lung disease, sleep apnea, or concomitant use of medications that increase their risk, such as benzodiazepines, or mental health comorbidities that may worsen opioid therapy, such as PTSD, depression, anxiety. We want to make sure our patients are successful during the opioid taper, so always ensure screening and treatment is offered for conditions that can complicate pain management, such as mental health disorders, evaluating risks of suicide and activating a suicide prevention plan, evaluating for opioid use disorder or other substance use disorders with a mental health provider, and during this time, avoiding abrupt discontinuation or rapid dose reduction to limit exacerbations of those conditions. Also, offering harm reduction strategies to minimize risk for our patients during the opioid taper, such as providing a medication disposal bag or even naloxone. Prior to making any changes in opioid therapy, always discuss the taper itself with the patient. You can discuss the patient's goals, not just being pain-free, but for instance, are they looking forward to spending more time with their grandchildren? And providing education on whether the risks and benefits of opioid therapy support that goal. Additionally, reviewing the taper steps, how will you support the patient, what alternative pain management strategies will you offer the patient, and ensure close support and follow-up. They should know that they're not being abandoned during this tough time, and making concrete plan that either someone in your office, such as yourself, another nurse, or a pharmacist will be following up with the patient to make sure they are successful during their opioid taper. And use shared decision-making. Correct any misconceptions the patient may have during this time, such as the ongoing new evidence of the safety and risks of opioid therapy, respecting the patient's autonomy, and not forcing the taper unless significant safety issues are present. Using motivational interviewing techniques may assist you with improving and obtaining patient buy-in. So let's go over some examples. Here I have some examples of communication strategies. For instance, using iMessages and asking for permission. I'm concerned about your safety with the opioid prescription. Can I talk to you more about this? I'm sure you've heard about the increase in deaths from overdose in patients taking oxycodone like yourself. These side effects usually happen due to a decreased rate of breathing. I'm concerned about your safety because of your past medical history of obstructive sleep apnea or COPD, which places you at a higher risk of opioid overdose. How do you feel about this? When the patient discusses their pain experience, always listen to the patient and validate their pain experience with reflective listening. They're the expert in their own pain, and we should respect them as such. We can introduce other pain management options that they haven't tried yet, we know to be even safer than opioids, and of course asking for permission if we can discuss it with them. When discussing their future goals, we can reset expectations regarding opioids. Opioids weren't meant to take away 100% of the pain, and we're considering opioid taper because you're not meeting your functional goals. You're telling me that it's not as effective for you. And we can try other options that may be safer for you. Here we have motivational interviewing example for a patient who does not want to stop opioids because they're the only thing that they have found helpful. You seem worried that stopping opioids will worsen your pain. Some of my patients have used these other pain management options that are just as effective or even more effective and safer in comparison to opioids. What are your thoughts on these alternatives? You sound as if you don't want to start the other options at this time. What are your concerns about these pain management strategies? And at this time, it may be appropriate to optimize these pain management alternatives prior to starting the opioid taper. We also have on one hand, you have the important goal of X. On the other hand, you're on chronic opioids right now, but you're unable to reach these goals. What are your thoughts? So on this slide, you have both examples of ORs and REITs. Determining the speed of the opioid taper can be more of an art than a science. The literature isn't really clear in how the taper should be dosed, what the schedule should be, but we do have some guidelines as shown here. Many specialists and practitioners do this differently. There's no really one single strategy, but for all opioid tapers, they should be individualized to the specific patient. Usually, opioids should not be abruptly discontinued. However, a rapid taper can be considered if opioids can cause significant imminent harm. This can be seen in the acute care setting where it's safer and a more quick tapering regimen is possible because of the increased intensive monitoring available. Usually in the emergency department setting, this may not be appropriate unless, again, medical safety requires it. A fast taper may be considered if the patient requests it or if they have not been on opioids for a longer duration of time. Usually, patients may be on a slower taper, reducing between 10 to 20% every 4 weeks with pauses as needed, but a very slow taper is definitely indicated in patients who have been on high doses of long-acting opioids for a very long time. When continuing the taper, always consider the ability to frequently assess the patient. How are they accessing their medications? Whether or not they're having difficulties accessing it from the pharmacy or are they obtaining it from a non-prescribed source. Usually these frequent monitoring visits are necessary so we can assess the patient's pain status, their function, and even if they have any withdrawal symptoms. Here I have some examples of when to follow up the patient, usually prior to each dose reduction. When following up the patient, always assess for red flags. This could be severe withdrawal, pain crises, worsening of mood, or impairment of their physical function, or other medical disorders that may require urgent evaluation, such as progressive numbness, weakness, changes in their bowel or bladder function, unexplained weight loss, internal malignancy that has not been restaged, or signs and symptoms of infection. If the patient is unable to continue the taper even after necessary pauses, you may assess them for OUD and transition them to MOUD as necessary. Be sure to offer comprehensive care during the opioid taper, whether this involves additional mental health support, acupuncture, meditation, yoga. We always want to make sure our patients are set up for success. And of course, managing symptoms for these patients, they anticipate that they will go through with, and so going over what the opioid withdrawal symptom timeline looks like, and so we can manage these symptoms and their expectations. Again, we always want to make sure our patients are set up for success. So here are some withdrawal adjuvant medications for such our patients. Usually I recommend clonidine, hydroxyzine, and loperamide for our patients, which tend to be common withdrawal side effects. Great. So let's move on to some special populations. For patients with cancer, opioid tapers are not very common. A very low percentage of patients with cancer are at risk or develop non-medical opioid use behaviors. There is some consensus-based guidelines that we will go over, reviewing opioid management in individuals with advanced cancer-related pain and opioid use or opioid use disorder. One of the main recommendations that they had was that in all cases, it's inappropriate to refer the patient to a methadone medical clinic. Initiating buprenorphine naloxone may be appropriate for untreated opioid disorder, regardless of prognosis. We can imagine there may be some difficulties providing this patient with buprenorphine naloxone, as many patients with cancer receive their opioid prescriptions from primary care providers, heme-onc, palliative care, who are not always comfortable with prescribing buprenorphine naloxone. For split-dose methadone, this may be appropriate for patients with shorter prognoses, but of uncertain appropriateness for longer prognoses. As you can imagine, the patient's cancer is within remission, then they are either in a situation where they have to go to methadone maintenance clinic or have their methadone tapered off, which may be difficult not just for the provider, but also for the patient. And full-mu opioid agonists are uncertain appropriateness for shorter prognoses and inappropriate for longer prognoses. For patients with no medical history of opioid use disorder, it is appropriate to increase monitoring. However, it is inappropriate to taper opioids and of uncertain appropriateness to increase opioids or transition to buprenorphine naloxone. And for urine drug tests that are positive for non-prescribed benzodiazepines, it is appropriate to increase monitoring and inappropriate to taper opioids and prescribe buprenorphine naloxone, and this is regardless of prognosis. The theme here is to increase vigilance, increase appropriate monitoring, and provide the patient with comprehensive pain management support. The next special population we'll be discussing is substance use disorder. For patients who are resisting further dose reductions, first explore the reasons for their reluctance. Are they having increased pain for a medical condition? Are they having worsening of their mental health, such as depression, anxiety? Or is it due to substance use disorder or opioid use disorder? They may require medications for opioid disorder if they do meet criteria, and this is outside the scope of this presentation. If this does happen, of course, work collaboratively with their patient's mental health providers. And if patients are not candidates for medications for opioid use disorder, you can consider transitioning them for buprenorphine therapy for pain. And in all cases, increase the mental health support for their patients. Again, we're going to set up our patients for success and make sure they're not having any anxieties about their opioid taper. Buprenorphine may be used as a bridge to help facilitate an opioid taper. So through its complex pharmacology, we can see that it delivers potent analgesia while having a dose-related ceiling effect on respiratory depression and euphoria. There's a decreased risk of addiction, tolerance, withdrawal, and even improvements in decrease in depression, suicidal ideation, hyperalgesia, sedation. There's reduced constipation with buprenorphine as well. So you can see here lots of benefits when considering transitioning to buprenorphine. So of course, we want to set the patients up for success. What are the risks or benefits of continuing the opioid taper while the patient is on buprenorphine versus continuing the patient on buprenorphine for pain control long term? When transitioning the patient to buprenorphine, do not forget the withdrawal adjuvants. We want to set the patient up for success. And of course, we have some literature that buprenorphine may actually assist patients with managing opioid withdrawal. It's actually seen to be more effective than clonidine in terms of managing severity, duration, and likelihood of treatment completion. We also have emerging data for naltrexone and facilitating buprenorphine discontinuation if you're going through the buprenorphine taper route. This naltrexone method does require a compounding pharmacy and injection. However, this may be an option for patients who are, of course, struggling with maintaining opioid abstinence. So ideal candidates for patients for using the buprenorphine bridge may be individuals at high risk for traditional opioid therapy, such as a history of drug overdose, if they have concurrent use of CNS suppressants, if they are a special population, such as older adults, if they have renal or hepatic impairment, or even patients who are have poor or unpredictable gastrointestinal absorption. While considering which buprenorphine product to use, always consider whether an X waiver is required, as prescribers may not always have an X waiver, and may consider continuing the taper even after the buprenorphine dose is stable. When starting the patient on buprenorphine therapy, try to evaluate baseline parameters when possible. However, you can assess the risk of delaying treatment versus the risk of delaying labs. I also have duration and parameters listed on the slide. When considering buprenorphine bridge for opioid tapers, here I have the traditional formulations for opioid use disorder that can be used off-label for pain. Here I have the traditional buprenorphine initiation method, which includes sufficient withdrawal symptoms for patients who require adequate analgesia. The dosing interval can be adjusted to 2 to 3 times daily to provide sufficient pain reduction. An alternative approach may be appropriate for patients with concern of or history of intolerable precipitated withdrawal. And in this situation, the full opioid agonist would be continued for 48 days. This would include having harm reduction strategies such as providing a medication disposal bag for any of the remaining full agonist opioids. The sublingual buprenorphine will be titrated to the lowest effective dose for the management of the withdrawal and cravings as they tolerated, and this may be further up titrated as clinically indicated, although this may require tablet splitting. Here I have chronic pain formulations of buprenorphine. As a brief introduction, we have the Butrans and the transdermal patch. I have the initial dosing here, which is by MEDD, and the maximum dose of note is 20 micrograms per hour of the transdermal patch and 900 micrograms every 12 hours for the buccal film. Here I have some additional clinical pearls for the buprenorphine chronic pain formulations. If conversion is required, I pulled some conversion factors from a pharmacokinetic study. The reason why the maximum dose of both medications were previously stated was due to the risk of QTC prolongation. Just to assuage clinicians' concerns, the risk of QTC prolongation with buprenorphine is dose-related. So if you're having a patient start at 24 milligrams per hour and you reduce them to approximately 20 micrograms per hour of Butrans, if they were able to tolerate the higher dose of buprenorphine, it's very highly likely that they're going to be able to tolerate the lower dose of the buprenorphine transdermal patch. The effect is opioid moiety specific, so this means this does not interact the same way a traditional QTC prolongation medication would be. Buprenorphine, although it can increase QTC, it is not clinically associated with torsades. There was a 9.2 mean increase with 40 micrograms per hour of Butrans, and for multiple patients, this may not be clinically significant. And of course, always assessing patient-specific risks and medication-specific risks that the patient is taking. If the MEDD of the opioid regimen that the patient is currently taking is higher than the package insert recommendations for conversion, I have examples of a start regimen here. However, if you prefer cross titration, I have this alternate approach where, again, patients will continue their full opioid agonist for 48 days and continue this full opioid agonist as needed, where their buprenorphine buccal film is titrated to the lowest effective dose. For patients who are stabilized, such as they have no withdrawal, intolerable pain, before reaching the proposed end dose, it's not necessary to proceed with further buprenorphine dose escalation. In summary, weigh risks and benefits when initiating opioid taper. Does the opioid regimen reach the patient's goals? Utilize communication techniques when obtaining patient buy-in using motivational interviewing. Devise a patient-centered comprehensive opioid taper, including pauses, follow-up, and communicating the steps to the patient, and considering buprenorphine as a bridge during an opioid taper. For your time today, if you have any questions, please feel free to contact me. For completeness, I have additional information here, and this is the last slide, having additional information, again, just for completeness. Thanks. Goodbye.